What's up, my peeps? Welcome back to the Dude Nurse Show. This week, we are going to be talking about the opioid crisis. Yep, that's right. Couldn't avoid it. I told you guys we would be talking about this, and here we are. I know there's been a lot of information about that in the news. It seems like every day or every week or every month, whatever, some new politician takes up, the war on drugs, and now it's seemed to have spilled over into prescription drugs. Don't get me wrong. I definitely think that there is a problem with prescription drugs in this country and how they're handled, and I definitely think we could improve, but I also have some other opinions which we're going to talk about. So let's talk about opioids. Let's talk about prescription painkillers. Okay, what do they do? Well, they kill pain. Somebody comes to the doctor and they have pain, and that doctor or nurse practitioner or whatever writes them a prescription for a painkiller. Now, that painkiller doesn't necessarily have to be fentanyl. I know that's a big word everybody hears in the news. Fentanyl. Some people pronounce it fentanyl. It's fentanyl. However the hell you want to say it, I don't care. That is one of the most powerful painkillers that we have in existence. Okay, it's extremely powerful. But Tylenol is a painkiller. Ibuprofen, aspirin, they have less more innocuous kind of drugs than, some of the stronger stuff. Norco, Vicodin, Percocet, Demerol. I mean, there's tons and tons and tons and tons of this stuff, okay? So you go in, you have pain, and you get this painkiller. Hopefully, after a while, you've been taking it, that pain subsides, and you're fine. You don't have to keep taking it anymore. Some people, that would be what we refer to as like acute pain. Some people have chronic pain. So the main differences between acute pain and chronic pain: acute pain can actually be a good thing. Acute pain tells you if you're running and all of a sudden you break your knee. Acute pain is basically your body telling you stop, quit moving, don't go any further. You're going to cause more damage. Okay, it's like I said, it's a good thing. It can stop further damage. It can point to where there's a problem. It can, guide practitioners in a lot of ways. Chronic pain serves absolutely no physiologic basis, and by that I mean, like I said, with acute pain, it does serve a very basic physiologic purpose, and that is to prevent further damage. Okay, perfect example: you put your hand on the stove, immediately you take your hand away, assuming the stove was hot. Ha 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 ha. Just kidding. Chronic pain, again, as I said, serves no physiologic basis whatsoever. It's strictly debilitating, and it doesn't do any good for the individual. Many people suffer with chronic pain: chronic back pain, chronic knee pain, chronic neck pain, chronic hip pain, chronic foot pain, chronic leg pain, whatever the hell kind of pain they have. So sometimes these individuals end up taking painkillers for years and years and years, okay? And sometimes the painkillers stop working. Painkillers, a lot of them, the opiates, have what's called a ceiling effect. Basically what that means is, let's say a person's taking 100 milligrams of something, okay? And a ceiling effect basically means that I can increase the dose of that painkiller to 200 milligrams. Okay, so we've doubled the dose. But guess what? They're not going to get any more relief, even though we've doubled the dose. But the side effects will still continue. So that is basically what a ceiling effect is. Okay, and so with that being said, we sometimes practitioners end up in a little bit of a kind of a quandary. It's kind of a double-edged sword. We have patients coming in. We're taught to believe our patients. We're taught to a lot of times, take their word at face value. A patient comes in and says, "I'm in severe pain." Pain is what we consider the fifth vital sign. Now, sometimes we look at things, if a patient's sitting there, calm, cool, collected, no other signs of anything going on, vital signs normal, everything's looking great, and they tell us that their pain is a 10 out of a 10, with 10, 10 is the worst possible pain they've ever imagined. We might need to dig a little deeper and figure out, okay, maybe you don't quite understand the pain scale. So patients can certainly manipulate facts and things. Some people you probably heard the term drug seeker. We run into that a lot. But I think it's oftentimes unfair to label people drug seekers, especially sometimes when a person comes in and they say, yeah, I don't want this. I've tried that. It doesn't work for me. That doesn't make them a drug seeker. It makes them a person who doesn't want to be in pain. As I said, with the chronic pain especially, chronic pain is extremely difficult to treat. I don't care what kind of pain it is. It means that it's a chronic, meaning that it's not going to go away. We haven't found a way to relieve the pain. And obviously the goal of pain control is to eliminate the pain, but that is not always a reasonable thing that we can do. So when I'm talking to a patient, if they're telling me that their pain usually on a daily basis is 7 or an 8 out of a 10, okay, that's pretty severe pain. Then I'll ask them, what's a good pain goal for you? And they may say, what, if you can get my pain down to a 3 or a 4 or a 5, that would be great. Okay, now I have something to work with. I never, ever, 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 ever promise patients that I can completely take away their pain, because like I said, that's not always the case. But again, that's always the underlying goal. We don't want people to have pain at all. But again, sometimes we just simply can't take away 100% of their pain. So we go after specific pain goals for our patients. Okay. So that being said, now we have a treatment plan in place, and maybe this treatment plan is working, maybe it's not. Sometimes people have what we call breakthrough pain. So we usually try to put a patient on a longer acting pain medication so that their pain is controlled over a greater period of time, so that if they have breakthrough, then maybe we give them something like Norco or Tramadol or Norco, Vicodin, whatever, to address those spikes in pain when that long-acting, like morphine ER or OxyContin or something along those lines, something that is meant to last over a period of 8 to 12 hours or so, then they can use the breakthrough pain. So if a patient is having to use those breakthrough medications, every 4 hours on the hour, every single time it's time, they're ready for it, and their pain's hitting 7, 8, 6, 7, 8, 9. We're not doing a very good job of controlling their pain. So sometimes we have to adjust these things. Okay, so this was more meant to kind of give you guys an overview of kind of how we look at pain and how we can kind of control it. The problem with this opioid crisis, or that we're perceived to have, and again, I think we do have a problem, but the the problem is not inherent in prescribing patients pain medication. It's it's a lot of these physicians and these providers, they're not doing their due diligence with some of these patients. Okay, so if I write a prescription to a patient, that means that I should have done some sort of assessment. Okay, it doesn't matter what the hell the prescription is: antibiotic, painkiller, fungal cream, whatever the hell, something for dandruff, whatever it is. I write this prescription, and then at some point, a week, 2 weeks, 3 weeks, a month, whatever the hell it is, there needs to be some follow up. Okay, but what happens is in a lot of these cases is that these providers just continuously refill these pain pills, and there's no follow up. Sometimes they may not even see these patients, and it's crazy. It's almost like they turn their own practice into some sort of a pill mill, and those are just, I mean, you might as well call the DEA and say, hey, here's where to come and find me, because they are going to crack down on you with the wrath of God. I mean, as well they should, because you're not doing your due diligence and following up with these patients. And then at some point, if you have a patient and even if you're a doctor, they're getting out of kind of what your scope allows, they need to be referred to a pain specialist. They have them out there. Okay, they have these people that's what they do. They manage different types of pain. There's so many different treatments available for managing certain types of pain, that we can do nerve blocks, we can do pain pumps. I mean, there's so many different treatments out there. There's physical therapy, there's rehab type programs, there's surgeries, there's a bunch of different tools within our arsenal. And what I see and what I hear from some of these morons in Washington is they just talk about, we have an opioid crisis, people are overdosing from all of this stuff. I mean, that doesn't mean that the real patients who need this stuff shouldn't be able to get it. I went to a different PCP a few weeks ago, about 3 or 4 weeks ago. I've taken a medication called Xanax or alprazolam, very low dose. I've been taking it for years. Never had any issues with it. I'm not addicted to it. It's not a painkiller. It's an anxiolytic. It's for anxiety. It is in the drug class of a benzodiazepine. Okay, and this clinic had a policy against prescribing me Xanax. They don't write it at all, and I think that's just absolute horseshit. It's horrible patient care. A person who needs this stuff. I'm not some junkie. I use this stuff. It helps with my anxiety. I also take a medication called Lexapro. It's an SSRI antidepressant, and it's helped me. It's helped keep me out of the ER over the years, over the last 14, 15 years. I had my first panic attack in 2005. I thought I was having a heart attack. And over the years, I've gone to the ER so many times because I thought I was having a heart attack, but I was having a panic attack. Okay. And over the years, I've learned to control it. And then, once I got kind of stabilized on my medication, I'm on a very low dose of the Lexapro. I have a very low dose of the alprazolam, 0.5 milligrams. Most of the time, I break it in half. It just helps me function and keeps me out of the ER. And I've done a lot of the work on myself. But for them to tell me, that it's against their policy, And I'm like, well, why don't why the hell do you treat people at all? I mean, you're only going to treat certain conditions. I don't understand why these doctors are afraid to write these damn prescriptions. If they do what the hell they're supposed to do, there won't be any issues. You don't refill these medications, for giving patients 3 and 6 months supply and give them a year's worth of refill and all of that. I mean, you just don't. You don't even do that with like blood pressure medications, maintenance medications. At the most, maybe give them a 90-day supply, with 1 or 2 refills, depending on where you are with that patient. They're an established patient. You've got their blood results look good. Their blood pressure numbers are good. You've got them stable. So you don't need to see them every month. I'm not saying that. But you certainly don't need to write them, a whole bunch of prescriptions and refills for a year or more before you see them. I don't think that's prudent because you need to keep tabs on these patients. You're the one writing the prescription. So it's no different than if you're writing for Norco or Tramadol or Dilaudid or morphine IR, morphine ER, whatever the hell it is. You need to keep tabs on your patient, making sure that, hey, they're doing what they need to do. Some people will flat out abuse these prescriptions. They'll go through, 10 or 20 Vicodin in a day or two, and if they're calling in for a refill and you're not doing an assessment saying, okay, I just prescribed these. Oh, doc, the pain was so great. Okay, well, that requires a phone call. That requires additional dialogue so we can say, okay, what is going on? Because some people, the Norco isn't going to be enough. They're going to eat them like Tic Tacs, and it's not going to do shit for them. Maybe it's not the right type of pain. Maybe their pain is more neuropathic, in which case, we would look to prescribe a different type of painkiller. Opiates and whatnot aren't necessarily the best choice for neuropathic pain. So again, it goes back to doing what the hell you're supposed to do, and that's following up with your patients and making sure that what you're doing is working. It's why you make follow-up phone calls, and a lot of people don't do that anymore, and it's ridiculous, and shame on them. But this opioid crisis, people who are drug addicts, at the end of the day, they have a bona fide addiction. It is a medical condition. And where we get into so much trouble is we have, like I said, these assholes in Washington, these assholes in the police force. And I'm not knocking all the cops, but they're not very well trained to handle these types of people. So basically what we end up doing is we treat a medical problem like a legal problem. People who are drug addicts end up in the penal system, with heavy recidivism rates, and they basically, one strike, they'll never essentially be productive members of society. They probably have a felony because of some of these things, and it's because they have an addiction, and people say, well, nobody forced them to smoke the weed or smoke the crack or whatever. That's the stupidest fucking thing I've ever heard. Nobody forced these smokers to smoke. Nobody forced alcoholics to drink. Nobody forced these people to gamble. People get denied housing, all kinds of government subsidies and whatnot if they're a drug addict. You wouldn't deny a diabetic, help, because, diabetes is a disease. Nobody forced them to eat and become a fat fuck and not take care of themselves. And these smokers with the COPD and all of these things, we have to meet these people where they are. And when you start treating a medical condition like a legal, as a legal one, that's when you run into trouble, because you have people who are not qualified to make these types of decisions, making these types of decisions. And it really sucks. The mental health in this country leaves something to be desired, and that would fall under mental health. I mean, there's a lot more that goes into it, but addiction and treatment programs, all and the like. There needs to be a higher emphasis on prevention. Some countries have it where people can come in and shoot up heroin, and they've got Narcan on standby. I'm not saying that's the solution, but if you want to really get out there and make a difference, we have to remove the stigma. It needs to be decriminalized, because guess what? A person's not going to come and ask for help and say, yeah, I'm a drug addict, I'm a junkie, I'm shooting freaking, black tar, 5-6 times a day. I've probably got some on me. They're, because they're afraid they're going to get arrested, and so that's taking a medical problem and putting it into the hands of legal people, putting it into the hands of law enforcement, and that is absolutely going to discourage people coming forth and trying to do the right thing, because they're afraid they're going to get caught. I guarantee you, if every time a person were to come into Walgreens or Walmart or wherever the hell they get their medicine, and they ask for a vial of insulin, and a cop was right there and say, oh, yep, you're diabetes, yep, you're breaking the law, you'd have a hell of a lot more non-compliant diabetics. We have enough of those, but I mean, I'm just making that point where decriminalizing some of this stuff would absolutely help these people get the treatment that they need. There's a it's like this, this Me Too movement. If you try to take away kind of the stigma and the negativity with reporting these issues, that's not going to help anybody. We've seen that fail across the board. But nobody wants to man up and say, hey, we need to decriminalize and allow people to come in and say, hey, look, I have a problem, I need help. And I think that would certainly get the ball rolling in the right direction. So we're about out of time for this show. If you guys have any questions, comments, I know this is kind of a touchy subject, and I know I'm strongly opinionated, and I like when people disagree with me. I like to debate and argue, and I'll be honest, I love it. So bring it on, folks. Let's hear it. Let's start a discussion. That's the only way that things are ever going to change. If we do nothing, nothing will change. They say the definition of insanity is doing the exact same thing but expecting different results. Let's not be those people. Let's go after some results. Okay? Thanks again so much for tuning in. I really appreciate it, each and every one of you. Thank you for listening. If you have any advice or suggestions for future topics, please do not hesitate to reach out. Thank you. I hope all of you have a wonderful evening, and be well, folks.